Yes. Thank you so much, Francesca, for the introduction. And as she mentioned, I will be talking about data-driven phenotyping of sleep-wake disorders. So in the introduction, we already heard quite a bit about sleep-wake disorders. Worldwide, around a third of the population is affected by sleep-wake disorders once in their life. So around a third of you suffers once in their life from some sleep disturbances. And we also heard that sleep-wake disorders can massively reduce quality of life and life expectancy of patients. Additionally, patients are at risk for cardiometabolic, brain and mental disease, as well as they have an increased risk of accidents, for example, while driving the car for car accidents. And we also saw this figure before, so there are worldwide, there are more than 80 different sleep-wake disorders, and their landscape is quite disentangled. So we have disorders that you probably know, insomnia, which is the difficulty of initiating or maintaining sleep. We have sleep-related breathing disorders, where the most severe cases where you wake up during the night because your brain just stops sending the signal to breathe. And you have hypersomnia disorders, which I will come to in a bit. Then you have, of course, overlapping symptoms between these disorders. So, for example, patients with insomnia, obstructive sleep apnea, or narcolepsy type 1, all of which experience sleepiness during the day. So their initial complaint is excessive daytime sleepiness. And then we also have co-occurring sleep-wake disorders in patients. So 50% of patients with narcolepsy type 1 also suffer from obstructive sleep apnea, making the problem of diagnosing these disorders very challenging. Currently, the diagnosis of sleep-wake disorders is based on multiple tests. So we have the sleep-wake studies with the polysomnography and the data we just heard about. Then there's also some very limited molecular and biological tests that are conducted. And then most prominently are questionnaires, where patients are asked about their own assessment of their sleep and how well they slept. And then we, of course, also have their symptoms that are diagnosed by clinicians. As I said, most disorders are based on self-reported questionnaires, and there's only very few disorders that exist with clear biomarkers. So very briefly, I want to mention the central disorders of hypersomnolence, where we have I will look at three main disorders. You have narcolepsy type 1, which is a disorder where patients have excessive daytime sleepiness, and they have really a lot of trouble to stay awake during the day. So they would not be able to listen to a talk like this without having the problem of falling asleep. Additionally, these patients, they have cataplexy, which is when they experience positive emotions, they just lose all muscle tone and basically collapse. So this also happens in dogs, and there's very cool videos available online on YouTube if you want to check it out. Then you have narcolepsy type 2 and idiopathic hypersomnia, where this distinction is a little bit more difficult because they are closer together in how they present. And they actually have a very low retest reliability, because if you come to the doctor on one day versus a second day, you might be diagnosed with narcolepsy type 2 on one day, idiopathic hypersomnia on a different day, and even on a third day, you might be declared as healthy because their measurements are really not that reliable. So for this work here, we asked if we can use unsupervised clustering methods to disentangle sleep-wake disorders based on the current markers that we have available. So basically, to translate from a picture that we have on the left side, where everything is quite disentangled, to a clearer structure based on sleep-wake disorders. So we used the Burn Sleep database. That is a longitudinal data set that has been collected from 2000 to 2022, where there's more than 12,000 patients with more than 400 variables collected from the different modalities that I mentioned previously. Now, because of this data set is a clinical data set and it was collected in the clinic, so patients come to the physician, they fill out on paper tons of question and questionnaire. So we had to do a lot of data curation and to to actually be able to use this data. So this data was digitalized. We first had to correct for any mistakes that were made during digitalization, and also data curation, so getting rid of unphysical or unphysiological values. Then we performed feature and patient selection, because of course, not all patients filled out all of the 20 pages of questionnaires. So we had to quite scale down and select a good cohort of patients with clean data. Then we had the step of data normalization and data imputation, because there was a lot of missing values. And then finally, an unsupervised clustering algorithm. We hypothesized that patients or disorders with clear biomarkers would be easy to distinguish, and then that the disentanglement of the full cohort of sleep-wake disorders would be a lot more challenging based on the variables that are currently collected. So we started with a cohort of central disorders of hypersomnolence where previous work has been performed. We found 4 different clusters, so you can see on the right side, 2 of which are patients with narcolepsy type 1 that were clearly separated. And then we have 2 additional clusters with intermixed narcolepsy type 2 and idiopathic hypersomnia. Then on the left side, we have the features per cluster and disorder that we extracted. And if we take a look, we can see that especially cataplexy was the main distinguishing factor between narcolepsy type 1 and the other 2 disorders. But for the distinguishing between cluster 3 and 4, it was mostly based on sleep drunkenness and hallucination, as well as gender, and the mean sleep latency. This is in line with previous work. So with validating these results, we then moved on to the full cohort of sleep-wake disorders, where we really did take into consideration most of the disorders that were available. Here, we found 9 different clusters. You can again see at the bottom right, cluster 9, the cluster of patients with narcolepsy type 1 that were extracted. Additionally, we also had 3 clusters of patients with sleep-related breathing disorders, obstructive sleep apnea and central sleep apnea in green at the top. But the rest of the clusters were really rather intermixed in terms of their disorders. Here, a look at the features. We again have for narcolepsy type 1, we have the cataplexy, which was the clear diagnostic biomarkers. And then for the 3 clusters of sleep-related breathing disorders, we have their typical markers related to their breathing that is recorded, that is mostly distinguishing. So again, we have clusters of disorders with clear biomarkers, but the rest of the landscape was rather intermixed. Third, as a control analysis, we selected a control cohort where we only selected patients without sleep comorbidities, meaning that, for example, for narcolepsy type 1, we only selected the patients that did not suffer additionally from obstructive sleep apnea, but only from narcolepsy type 1. And to make the picture a little bit clearer, we only selected subgroups of disorders in each of the major group of disorders. So for insomnia, we only considered patients with chronic insomnia. Here, we also extracted 9 different clusters, and we have, again, clusters with related to breathing disorders and narcolepsy type 1. Additionally, we also found a cluster of patients with insomnia, but insomnia is rather intermixed as well with the rest of the sleep disorders, which is how it is known to present. If we look at the features that were extracted, again, for narcolepsy type 1, we have cataplexy, and then for the sleep-related breathing disorder clusters, we have their very distinguishing features as well. The insomnia patients had a rather high fatigue severity score, which is not what is 100% usually associated with insomnia. Yes. So in conclusion for this work, the disorders with clear biomarkers that currently exist, we were able to identify, but disorders without biomarkers, they were not identified based on the current markers that exist and are collected in the clinics. So there is really a huge need for new markers or a redefinition of current disorders. So there is really a need to collect in-ear EEG to be able to, for example, diagnose these disorders. So I want to acknowledge the supervisor of my PhD thesis, as well as the Sleep-Wake Epilepsy Center at the Inselspital in Bern that was providing the data. And thank you all for your attention.